Welcome to Psychiatry Grand Rounds. There is no commercial support for today's program. Any financial relationships of the planners and speakers with commercial interests have been mitigated. If you have a question for our presenter today, please hold until the Q&A segment. And if you're viewing online, you can enter it into the Q&A section. A link to the evaluation will be shared at the end of the program. And now I'd like to introduce Dr. Samuel Dodson, who is our Psychiatry Program Director.
Thank you. It's good to see everybody. We're starting off our Grand Round series for the year in our official location on Walters. Our last series was in the Green Tower New Educational Space, where we had some professors from Emory coming to talk about AI in medical education. Today, I'm very excited to welcome Dr. Benjamin Kinnear. Ben is a professor of internal medicine and pediatrics at the University of Cincinnati Medical Center in the Division of Hospital Medicine, and he also works at Cincinnati Children's Hospital Medical Center. He is the PD for the MedPeds residency program and the Internal Medicine STAR or Scholars Program Medical Education Fellowship there. His academic interests include competency-based medical education or CBME, as well as learner assessment, coaching, validity, augmentation theory, and compassionate off-ramps. Ben spends most of his free time with his wife and 2 daughters hiking, playing board games, and traveling whenever possible. He is a St. Louis Cardinals fanatic and strongly believes that mint-flavored ice cream is an abomination. Please join me in welcoming Dr. Kinnear.
Hey everyone, thank you so much. I also want to recognize that my take on mint-flavored ice cream may not be universally shared, and so if anybody has follow-up emails, happy to have that discourse. But I'm so excited to join you today. I'm sorry that I cannot be there in person. I'm actually on clinical service right now, but I'm excited to have this discourse. And what I'd like to talk about is competency-based education, or you may have heard it called CBME, for competency-based medical education, and how we can use this philosophy of training to try to rebuild trust with our patients and with society at large. My only disclosures are that I have gotten a couple of grants, one through the Josiah Macy Jr. Foundation, one through the AMA, that will reference some work toward the end of this talk. I will try to signpost that for you, but much of the talk actually has nothing to do with those grants per se. And here are my learning objectives. I hope after this you're able to talk about the rationale of CBME, including the core components for what CBME actually is, and then just kind of maybe imagine what medical education and health professions education more generally might look like if we had a competency-based approach. And I like to start off this discourse always with the why behind what we do. And when I say why, I mean, if you're in education in any form or fashion, why are you in education? I don't know about where you all practice, but here in Cincinnati, you know, education is not generally the best path to making more money or you know, garnering acclaim or anything like that. So usually there's something deeper that drives us to want to be in education. And I want to share my 2 most important whys with all of you because it actually informs the rest of the talk. These are my 2 most important whys. On the left hand of the screen, you have a group of my residents. I am a residency program director from MedPeds, and I really, truly love my residents. And that is not a hyperbole. I deeply love them as humans, and I feel really, really a great sense of responsibility that by the time they graduate training, that they are truly ready to do the jobs that they're going out to do. Now, this does not mean that they are perfect or they won't make mistakes, but it does mean that when I say, I trust you to go out into practice, that I really mean it. And on the right-hand side, you have my family, my wife and my 2 daughters. All of us see different healthcare professionals. Some of us have multiple doctors that we see. And as somebody who is part of the pipeline of people going into training as doctors, I want to know that when they see somebody who has gone through medical training, that those people are truly ready to do the job. And unfortunately, as we started measuring outcomes of training, there is some evidence that maybe we're not doing as well as we could do in terms of training the next generation of doctors. And really, my journey into this discourse started when this paper came out back in 2020. Now, it's a small paper. It's just a correspondence. It's a small qualitative study, but it really kind of shook me. And what they did was they reached out to multiple anesthesiology educators from several European countries, and they asked them kind of an interesting question, which was, would you trust your loved ones to be cared for by every trainee that you've graduated and certified? Not would you, the people that you've graduated, would you go to them first or are they the best, but simply, would you trust them to care for your loved one? And interestingly, about 40% of people who responded said, no, I would not trust everybody I've graduated to care for my loved one. And even more said, I'm not totally sure. And now when I read this, I was like, oh boy, that's concerning. I wonder what it's like in my backyard, in my specialty, or in my country. And it turns out there's some data on this. So there's an annual program director survey that goes out to internal medicine program directors every year, probably is the same for every specialty. And a few years ago, the second to last question on that survey, they snuck it in right at the end, was this statement. It says, I have graduated at least one person in the last 3 academic years about whom I have concerns regarding their ability to practice independently. And over 50% of my colleagues said, yeah, I've done that. Meaning we are knowingly graduating people that we're not really sure that they should be graduated. Now, when I read all this, again, I was really shaken. And I did what any really good scholar would do. And I went to social media and posted the same question. If you're a program director or a competency committee member, would you trust everybody that you've graduated to care for your loved ones? And interestingly, I found kind of similar numbers in this very, very scientific Twitter poll to what the actual studies showed. And to follow up on this, my good friend Dan Schumacher, who's a peds emergency medicine doc, did a survey in pediatrics. So you got both sides of my world, medicine and pediatrics. And when he surveyed national pediatric program directors here in the United States, 80% of people said they had graduated somebody despite having concerns about doing so. And 43% said they've graduated somebody that they wouldn't trust to care for one of their loved ones. Now, these are very holistic judgments. You're asking a single person, a program director. It's kind of one person's opinion. Doesn't give you a sense of like how big are the gaps or what are the skills that people might be lacking at the time of graduation. Well, this same friend of mine, Dan Schumacher, did a really, really robust study by the kind of standards of education research. And he looked at graduates from 63 med peds and pediatric programs in the United States, 63, almost 2,300 residents. And what they looked at was the outcomes of training as defined by what are called EPAs. Now, if you're not familiar with EPAs, EPA stands for Entrustable Professional Activity. All it is a unit of work or a task that we expect people to be able to do with increasing levels of autonomy. And hopefully by the end of training, they can do it without supervision. And so the different skills you see there, those are actually EPAs. And there's a whole lot of definitions about what each one of those things mean. I just kind of abbreviated them to fit them on one slide. But these were developed not out of whole cloth. They were co-created with the American Board of Pediatrics, pediatric program directors, learners, patient representatives, pretty much any stakeholder in the medical education process you can imagine was brought to the table to help co-create these EPAs. And they came up with 17 of them. And they kind of make sense, right? If you look at the top, you want people to be able to do health screening and care for newborns and provide a medical home for well children and those kinds of things. What you're looking at with the percentages on these tables is the percentage of those 2,300 residents in this 63 program cohort who were entrusted to do each of these EPAs at the time of graduation without supervision. So, for example, the highest entrusted EPA here was health screening, and 89% of those 2,276 residents graduated while being entrusted to do it without supervision. Now, that doesn't mean if you're not in that 89% that you're totally discompetent, but what it means is your program and your program director who have been assessing you for years and who know you well said, you are not ready to do this skill without supervision yet. Okay, so if you take the flip of this, just the inverse of it, this is the percentage of graduates who were not entrusted to do each of these EPAs without supervision and yet still graduated. Let me be clear, all these residents graduated, it's just what percentage of them weren't trusted. And so if you go down to the bottom left hand of that table, one of the EPAs is treat acute common diagnoses. That's pretty straightforward for most pediatricians. Earaches, strep infections, pneumonia, stuff like that. 1 in 4 were not trusted to do that without supervision and yet were graduated. If you go up to the upper right-hand corner, behavioral and mental health, 1 in 3, not trusted to do what a basic pediatrician should be able to do, not act as a psychiatrist, just do kind of frontline primary care for mental health, or resuscitate and stabilize a patient. Again, not asking you to be a PICU doc or an ER doc, but can you do what you need to do to keep a patient alive and resuscitate them in order to get them to where they need to go? 40% were not entrusted to do it without supervision. And in the bottom right-hand corner, you got, can you do systems improvement and provide equitable care? A majority of residents weren't trusted to do it. So this one really grabbed me because it shows that not only are we commonly graduating people that we don't fully entrust to do the job without supervision, but there really are multiple different EPAs or tasks that there is a gap between where we want them to be and where they are. And again, this is not saying that medical education is failing writ large. It is not saying that all of our learners are discompetent. But what it is saying is that if we imagine that we are training people to be able to do the job without supervision at the time of graduation, we're not quite getting them there. And this is not just a problem for at the moment of graduation, but it's a problem that actually echoes forward through time because there's evidence more and more that we are what we repeatedly do, as Aristotle would say. And let me tell you what I mean by that. This was a study, a very famous study now in medical education from 2009, I think. And what they were looking at was obstetrical outcomes for providers who are out in practice in 2 states, Florida and New York. Okay, so they're looking at obstetrical outcomes for people who are in practice. These are not residents that they're looking at. And they were looking at 9 maternal complications, things that are commonly tracked in obstetrical practice. So laceration rates, hemorrhage rates, infection, those kinds of things that you can track and measure and see how you're doing from a quality of care standpoint. And then what they did after they looked at almost 5 million hospital admissions and looked at the quality of care connected to the provider, they went back and looked at where those people trained. And they asked the question, if you trained at a place that provided high quality care on these metrics, did you yourself provide higher quality care when you got out into practice? And if you trained at a place with lower quality care, did you provide lower quality care when you got out into practice? And when they broke things down by quintile, what they found was if you trained at an institution that had low complication rates, so the top performing programs, you yourself had lower complication rates when you got out into practice, even when you adjust for local practice patterns and all the other things that kind of make practice idiosyncratic to a given institution or region or patient population, trying to control for all those variables. If you learned to practice medicine in a way that you had low complication rates, that was your practice pattern for years into practice. And for every quintile of increase of complication rates where you trained, the higher the complication rates were when you got out into practice, again, even when trying to control for all those confounders. So that's not to say people can't grow and get better, but there is a level of imprinting that happens in training in terms of quality of care that will lead to differential outcomes long term. So it matters that we get this right. And in this particular study, the difference in absolute outcome rates between the top performing and lowest performing programs was over 3%. Now, as an internist, if I got a drug that has an absolute 3% difference on something, I'm like, I'm winning some sort of prize. So this is huge. The idea that education can be an intervention that actually has significant impacts on downstream patient outcomes should really, I think, give us a lot of hope that our jobs have meaning as educators, but it also should give us a sense of responsibility that we have to get this right. And we can't just pass the buck or kick the can down the road if somebody's really not ready to go. And this wasn't just shown in David Ash's study. This has been shown in multiple different studies that whether you're talking about surgical outcomes or spending patterns or how you practice end-of-life care or patient-centeredness and on and on and on, that again, the patterns and quality of training programs become the patterns and quality of healthcare professionals after training, that we are what we repeatedly do. Again, it's important that we get this right. And it kind of makes sense when you look at how we as physicians choose our own healthcare providers, because I think we all kind of know implicitly that sometimes we graduate people that maybe aren't fully ready for practice, and yet they still graduate. And that's why when we choose our own doctors, when we ask, well, who do I want to be my surgeon or my oncologist or my family's oncologist or surgeon or whatever, we don't trust that the education system does its job. We ask our friends. We ask around and say, who's really the best surgeon? Who's really the best oncologist? Who's really the primary care doctor that I want? Because we know that there are people who go through training and don't get where they need to be, and yet we still graduate them. And I think this is one contributor to the growing lack of trust that society has in healthcare. I think there's a lot of other reasons too, some of them legitimate, some of them cynical, but there is a growing trust problem between patients and society in general and the healthcare system, and sometimes with individual doctors. And this is not completely new. In fact, the whole idea of competency-based education, which I'm going to define for you in a moment, started with a social accountability movement. The idea was people started saying, I don't know that the medical education system is actually delivering on its promise to produce high quality physicians. We need to reimagine how we're thinking about training. And that's how CBME really kind of grew into being. So this whole thread of, are we actually delivering on our promise to train high quality physicians and delivering on our promise to learners as well, to make sure that they are ready for the job they're about to do? I think we're seeing there's a bigger gap than we may have realized. And the competency-based education movement was one attempt to try to help this. Now, you might say, well, but haven't we been focusing on outcomes of training forever? Like, this doesn't sound novel. Like, isn't making sure that we train high quality physicians something that is baked into medical education? Well, in fact, it's actually not. And I want to just take you on a brief tour of the history of medical education in America to show you why it's not. So I'm going to distill this down into one slide. If any of you are medical historians, I'm very sorry. I'm not a medical historian. This is my amateur attempt to tell this story. If you go back to where medical education was in the America in the 1800s, I know that's really, really far back. It was literally the wild, wild west. If you wanted to be a doctor, you would do an apprenticeship. And you would follow somebody around and you would like learn bloodletting and leeches and lancing boils and all sorts of gross stuff. And that's how you became a doctor. So it was incredibly heterogeneous in terms of how you got your training and what the quality of physicians were. Now, there were some proprietary schools where you could pay money and go to lectures, and there were very few university programs. But early on, it was mostly an apprenticeship model. If you fast forward later in the 1800s, an organization was founded that eventually became the AAMC. And one of their charges was to develop standards for training, because they needed some sort of standardization of what it meant to train to become a physician. And after doing a lot of research and looking at what was going on over in Europe, especially in Germany, where they had much more kind of standardized training programs, they released a set of training standards in 1905. And these standards echo to today, because most kind of classic medical school setups where you do 2 years of pre-clerkship and then 2 years of more, patient care clerkship type medicine comes from this document. And it was not empirically derived. It was just kind of looking around at what the best schools at the time did. And they had what they called 2 years of laboratory-based medicine and then 2 years of patient care. And that became the standard for medical training. There was no residencies yet. It was just medical school. Now, the question was, as more and more university-based medical schools were popping up in North America, was what percentage of them were actually meeting these 1905 standards. And in 1907, there was a survey done across North America with 160 institutions that were visited and kind of sampled and surveyed. And what they found was about half of those institutions did not meet those 1905 standards. So there was still a lack of standardization going on. Now, most of you probably haven't heard of this 1907 survey because there really weren't any consequential ramifications of it. There were some political reasons why the AMA didn't want to squash a bunch of medical schools. However, just a few years later in 1910, there was another survey done across North America. It was almost an exact repeat of the AMA survey. And this one, many of you probably have heard of. It was called the Flexner Report. It was led by a guy named Abraham Flexner, who was not a physician, but he got some money from the Carnegie Foundation to go out and essentially do exactly what the prior survey had done. And he found the same thing. He found that about half of medical schools were not meeting the 1905 standard. Now, as medical training got more and more complex and patient care got more complex, people started doing additional training after medical school. And in 1919, you had the AMA starting to give guidance on what they called internships. And this is kind of what eventually evolved into residency. And by the late 20th century, you start having accreditation with the ACGME and the LCME and others. And so the reason I put this all on a slide is to show you that it took us 200 years just to kind of get our arms around standardizing training experiences, to say, we don't want to have apprenticeship models and bloodletting. We want to have some sort of standardized curricular exposure and experience that we know all physicians get to be different types of doctors, right? It makes a lot of sense. It took a lot of work just to standardize experience. But what was missing from a lot of this kind of curriculum evolution was a focus on outcomes. So while we did test people and we were evaluating people and evaluating programs, there was not as much of a focus on What is the outcome of our training programs? What is the quality of people, quality of physicians that we are developing through our training? It was just focused on standardizing the process. And something happened that shifted our focus from process to outcomes. And that event that kind of kicked off the whole thing wasn't even something that happened in medicine. It happened in space. And in 1957, when Russia launched Sputnik into space, Sputnik was the first satellite in space. Apparently people here in the United States really got upset. We kind of wanted to know, like, how could Russia beat us into space? Again, it's 1957. It's the height of the Cold War. Like, this was a big deal, and people kind of panicked. And they wanted to know, who do we blame? Like, who do we blame for Russia beating us to space? And education ended up landing in the crosshairs of blame, with the rationale being that if Russia beat us into space, they must have better engineers and physicists and rocket scientists and all those kinds of things. Therefore, their education system must be better, and we need to improve our education system if we're going to keep up. And so it's around this time that you start seeing words like performance-based teaching evaluation and outcomes-based education and competency-based education coming into kind of the zeitgeist of education. And a lot of legislation and funding was poured toward trying to get a more outcomes-focused approach to education, say, rather than just standardizing process, let's make sure we're actually creating good engineers and rocket scientists and all those kinds of things, and they can actually deliver on the things that we hope they can do. And so as far as when did that start to trickle into medical education, there's not a specific point in time, but many people point back to this 1978 paper by McGahey et al. As a place where it really came into our kind of consciousness in medical education, and has only kind of grown since then, with more and more of a focus on outcomes as this idea of accountability to the public has grown to the forefront. As we've gone into the 21st century, you've got things like the CME milestones and EPAs and all these other things. And people have started writing about a paradigm shift from the Flexnerian model that I just described to you to a more competency-based model where we focus on outcomes of training as well as process, not just process. So just to summarize it at a very high level, this is kind of the classic Flexnerian model that we've been working under for hundreds of years, where somebody writes a curriculum that may just be founded in preference and tradition, and from that curriculum, objectives and assessments come, versus the competency-based model, which at a very high level is essentially looking at the needs of our patients and our health systems, determining what we need our learners to be able to do to meet those needs. And we often frame those in terms of competencies, but you can frame it many different ways. And then letting those competencies dictate what our curriculum should be and what we should assess. So it's kind of a way of like starting with the end in mind and working backwards. Now, when you try to implement competency-based education, it's really hard to translate this very, very simplified figure into actual, boots on the ground, frontline educational reform in terms of curriculum design and assessments and all those things. There's a lot of different ways that this can look, because this is a high level way of looking at it. And I just want to point out that is not a bug. That is a design feature of competency-based education, because competency-based education is not a checklist. It is not a you must do this or that. It is not just stapling milestones or EPAs onto an existing curriculum. It is actually a philosophy of training. It is an approach to training that is grounded in certain principles like feedback and development and a focus on outcomes and those kinds of things. With that in mind, there are many, many ways it can look. Competency-based education in my Med-Peds residency program might look very different than in your psychiatry residency program, or different in medical school, or different between medical schools. It can manifest differently as long as you're adhering to this kind of philosophy of training. Now, if that's true, the question becomes, how do you know if you're actually adhering to that philosophy of training? It's kind of like saying democracy is a philosophy of governance, but it can look many different ways. How far can you innovate within that philosophy before you're not practicing democracy anymore? Well, some years ago, some really smart people sat down and wrote down what they called the core components of competency-based medical education. They said, within this overarching philosophy, these are 5 things that we think are core to saying that you're doing competency-based education. And as you're thinking about implementing it, or even evaluating your program, these are the things you should aim for or evaluate. And what I'd like to do is walk through each one of these, giving a brief example and maybe even a slight argument for why it's important. And then we'll kind of bring it all together at the end, because I do think all of these things are in service of improving training to improve care for our patients and improve their ability to trust in our system. Now, the first two, outcome competencies and sequence progression, I'm going to lump these together because they so often go hand in hand. But the idea is, if you're going to have an outcomes focus of training, you need to kind of have an idea of what are the outcomes that you care about so that you can both build curricula around them and also you can assess them. And so much time and effort has been spent over the last 20 years as we move toward this competency-based paradigm on these first two things. This is why we now have things like the ACGME subcompetencies, or I believe you guys all, psychiatry now has entrustable professional activities, and many specialties are developing them. But this is not unique to physicians. There are physical therapy subcompetencies. There are nursing competencies and entrustable professional activities. This spans the continuum of medical education, from medical school to GME on into CPD. So there's nothing unique about the ACGME milestones or any specialties EPAs. They are simply a way of trying to outline what are the outcomes of training that we care about so that we both know how to build our curricula and what to assess. And I want to point out that every single outcomes framework I've ever seen is flawed. It's flawed because you are trying to outline what are the most important outcomes you care about. And every time you have to draw a line to delineate that, you are leaving something out and you are pulling something in. And there will always be revisions that need to be made, disagreements about what should be included or shouldn't be included, or how specific are you or not. So any outcomes people develop for competency-based education should not be seen as a static end-all be-all piece of information. It should always be undergoing revisions because you will always find flaws in it. I've been in the room for some of these subcompetency milestone things that the ACGME has done, and it is a good faith effort to get many stakeholders together, including learners and frontline educators and program directors, et cetera, and to try to the best of our ability outline what are the important outcomes of our specialties. And it is a flawed, messy process, but that does not mean that these outcomes are without value. I do think they have value. So that is the first two core components. Have your outcome competencies, whatever framework you want to use, just outline the outcomes of training that you care about. And the sequence progression part is, can you do it in a way that you allow for growth and development? That you don't expect people on day one of a training program to be able to do something that a seasoned trainee should be able to do. And with the two frameworks that we use most, the milestones and the EPAs, those are both sequenced and developmental in their very nature. For milestones, you don't expect people to be able to all the way over at level 5 when they get to start training. We expect them to be levels 1 and 2 and then eventually work their way over. And with EPAs, they are inherently developmental because they are based on a supervision scale. And we expect you to need a lot of supervision early, and that supervision should hopefully decrease as you go through time and gain competence. So kind of baked into the very nature of these frameworks is this developmental sequence progression, but there's other ways you could do it too. Milestones and EPAs are not the only way that you can think about doing this. Okay, this third one I think is where people get most stuck with CBME. And I think sometimes CBME is just conflated with just more assessment, but it doesn't have to be. However, one of the core components is what's called programmatic assessment. So what does programmatic assessment mean? Well, for a long time in medical education, assessment was mostly done with multiple choice question tests. And there was good reason for this. You could administer them to a lot of people all at once. You can do it in a very standardized way. When you're looking at building validity evidence for a given assessment, you can build some really good psychometric evidence that a test has good reliability and is measuring the constructs that you care about. So these tests have value. But over time, people realize, while these give you some valuable insight, they do not measure fully all of the competencies that we care about. And so programmatic assessment says we should probably have many other ways of assessing our learners, whether it's case-based discussions or simulation or OSCEs or chart audits, or more and more we're using this workplace-based assessment where we're actually seeing people in the authentic clinical environment. And we should integrate them together in a deliberate, systematic way, not just throw stuff at the wall and see what sticks, but look at the outcomes we care about and take the assessment approach that is fit for purpose to get at that and then integrate them together so we can get the best picture possible of what our learners can and cannot do, and then use that data not just to make decisions about readiness for practice, but also to support their growth and development, as well as program evolution over time. How do you make the program better? Excuse me. So just as one example, at our internal medicine program here at University of Cincinnati, we have a ton of workplace-based assessment where every single rotation has a bespoke assessment instrument that is used and was co-created with the rotation directors and learners. We then collect lots of observational data, never presuming that any given rating is the entire truth about a learner, but has some truth about them. And we use homegrown analytics to try to find signal from noise. So how much of the rating is due to who's given the rating or what time of year it is or what rotation they're on. We put it all together on a dashboard that we spend a lot of time trying to make sense of, and we share that dashboard with our learners so they can use it for their own growth. We look at actual clinical care measures when our residents are embedded in a longitudinal ambulatory experience for an entire year. We say, what happens to your patients? What happens to the quality of their care? Both process measures like checking certain screening labs and cancer screening, and outcome measures, including things like what is their A1C and what is their cardiovascular mortality. We look at 360 assessment, where we get feedback from not only the learners themselves, but their peers, their faculty, our staff, and the patients. We have a homegrown testing program that was developed by one of our brilliant faculty, Dr. Brad Mathis, that not only gives us a sense of their medical knowledge, but it also shows us how do they use the learning resources that they have access to. So it's kind of a sense of their master adaptive learner tendencies and self-directed learning. We have like a get stuff done dashboard where we say, are you doing your modules? Are you getting your vaccines? Are you doing, are you closing your charts on time? All the things that are kind of part and parcel to being a self-sufficient physician. And then probably most importantly, we collect a ton of narrative data. And we don't just collect it, we've actually done some research to try to build theories around how to interpret that narrative data. Because as we all know, people don't always say things outright. Sometimes you have to try to read between the lines. And so we've tried to do some work to help us decode what those things mean. And we have multiple people kind of access those. And we use this for reflection and growth with our learners as well. Now, once we collected all this, which is, this is like many years of work trying to build all these tools to get some robust assessment, we also spent a lot of time thinking about how do we use that data? And in our competency committee, which is our group of people who sit down and look at the data and provide feedback to learners and also make decisions about promotion, we spent a ton of time looking in the medical education literature and beyond into other fields like communication and business to say, how do groups of humans make good decisions or make the best decisions possible? And what are the processes and rules that we can try to follow? And we've really spent a lot of time on that. So you can't just collect data, you have to do something with it. And all of these pieces of the system are flawed, but how do you put them together in a way where you can find value and maybe make defensible decisions about readiness? That's programmatic assessment. The fourth one is called competency-focused instruction. What does that mean? Let me start by saying what it's not. Again, for a long time in medical education, the main reason that we assessed people was to rank and sort them. It's very normative based. We love ranking and sorting people. Normative means comparing between people and groups. So for example, we really want to know who's the best and who's the worst. We want to know, are you honors or what quartile you're in or all these things. These are all normative ways of looking at assessment. And there are some benefits from trying to do that, but there are many, many downsides as well. And what normative assessment doesn't tell you is what a person can or cannot do. Because you might be the worst person in a group of other people, but you can still do all the things that we hope you can do at the time of graduation. So it doesn't really give you meaningful information as opposed to criterion-based or criterion-referenced assessment, where you're not focused on comparing people. You're just trying to say, this is what I want you to be able to do. This is the criterion I'm aiming for, whether it's on a milestone scale or an entrustment scale or whatever framework you want to use. The goal is to get you there to make sure that you are competent to provide good patient care. And I don't care if you're the best or the worst. And I want to be really clear that criterion referencing, having criterion-based assessment, does not mean we are trying to make everybody the same. The goal is not a homogenous group of doctors, because we want a diverse group of doctors going out to serve our diverse patient populations. And I mean diversity in every single way, whether it's interests, strengths and weaknesses, identities, all these things. But what criterion referencing does mean is that the goal is that everyone is good enough. And when I say this word, when I talk about competency-based education, when I say good enough, people kind of like gag a little bit in their throat because it's so unaspirational. It's so unaspirational to say, oh, good enough. Oh, I don't want to be that. I want to be amazing. I want to be excellent. And I think that's actually true. This is one of the critiques people have of competency-based education, is saying competent sounds so, like why aim for a floor? But what we always have to remember as a medical education community is that we get to define what good enough means. We get to define what competent means. It doesn't have to be a low floor. What if good enough didn't mean good enough? What if it meant good enough to care for my kid? What if it meant good enough that if my wife were sick and I showed up at the hospital, I would feel comfortable the people taking care of her are going to do a good job? That's a pretty high bar. So instead of doing what we've always done, which is just trying to sort people between best and worst in terms of our assessments and having the line of good enough or competent down here, what if we move that line up here? What if we set really high standards for what competent meant? And then our job as educators and as programs is to get as many people above that bar as we can, and not worry about who is the best and not rank and sort people, because the bar of good enough is so high that it makes the best and worst irrelevant. This should be what we should be driving for. And I'm not saying we can snap our fingers and do it, but our whole system is set up for ranking and sorting people, when our goal should be, let's set a really, really high bar and then invest in getting as many people above that bar as possible. And the place where you see this happen the most is probably with airline pilots. When you get on a plane, maybe you do this, I don't do it, and I've never seen anybody do it. I don't turn as I'm getting on the plane and look in the cockpit and say, excuse me, ma'am, where did you finish in your pilot's class? What quartile were you in? Because every pilot lands the plane every day. What if we had a system where that was the case? What if we had a system where we didn't have to leverage our connections to ask friends who's really the oncologist that I want caring for my loved one or myself, right? What if we could trust the system that we are contributing to? That is what competency-based education is. And I also want to be clear that competency-focused instruction isn't just trying to get people above this aspirational bar. It is also giving them the skills to stay above that bar, to be self-directed learners forever. If you look at what learning looks like, this is actually some work from Bill Cutrer and Martin Pusick and others. Learning is not a linear process. It actually looks like this kind of S-shaped curve. And what you're looking at is performance on the y-axis. So you can imagine that as like knowledge or skill or whatever you want. And on the x-axis is the amount of time practicing. And so ideally, you would imagine the more you practice something, whether it's studying or repetitions or simulations, your performance should go up. And it does, but it's not linear. This is empirically derived. When you do this work, initially, there is very little return for the effort you put in. That's why the beginnings of that curve in the bottom left-hand corner is flat. You can work really hard and feel like you're just spinning your tires. And I think all of us have experienced this early in medical school or early in residency or anytime we're learning a new skill. Early on, it just feels like we're working really hard and we're not learning much. And then there's this explosion of growth where the curve kind of goes much more vertical and you just take off like a rocket. And I remember that in residency too, where I really hit my stride right around second year. And I felt like I was growing by leaps and bounds every single day. I'd learned the system. I'd learned how to learn. I was a little less, just so focused on performance. And I got to focus more on growth and learning. And I just took off like gangbusters. And then as you hit a certain point of expertise, things level off. The amount of return of performance or expertise that you get for ongoing effort, again, diminishes because you've already hit some kind of close to peak performance. Now, when you get to that flat level, there's like a couple of different trajectories you can take. One is to level off and be what you see there as an automatic expert, or sometimes you don't even become an expert. You become what's called a experienced non-expert. But you level off and you flatten off because you are no longer really pushing yourself to grow and you stay flat. Or you can develop the self-directed learning skills to continue to push yourself, even though the growth is less for the amount of effort you're putting in, and you get on that upper curve, and that's called a deliberate expert. Those are the people, we all know them, who are like going the extra mile to close those knowledge gaps, even though they've been in practice for 20 or 30 years, and they are still growing and growing and growing. And those are the people who are the best amongst us in terms of clinicians. And here's the main reason why we have to get people more on that upper curve, because that lower curve, where it says automatic expert, that actually doesn't stay flat forever. That actually bends down over time. There's study after study that shows knowledge and skill decay. And in fact, at least in internal medicine, there is multiple studies that show that mortality and cost of care and length of stay goes up the further out of training you are. So I'm 12 years out of training. I probably have worse outcomes now than I did when I was a second year attending. That's what the data show. My friend Jason Frank always says, competence is a downward escalator. If you don't have a deliberate approach to learning, you can get above that bar of excellence, but you're going to sink right back down. So how do we, as part of our training programs, not just do the hard work to get people above that bar, but give them the skills to keep going up, because otherwise they're going to sink back down. And there's a whole really rich body of literature out there on what the science of learning looks like. One of my favorites comes from the AMA. I'm not part of this work, but it's called the Master Adaptive Learner Model, which brings together the coolest theories we have on metacognition, on the science of learning, on motivation, and all these different things to say, what does self-directed learning look like? And it actually looks a lot like a plan, do, study, act cycle. And if you teach your learners these skills, which we do in our coaching program here, then they can carry it forward once they get beyond the bounds of your training program. That's competency-focused training. If I had to sum it up into one sentence, I'm going to borrow from a qualitative study we did. It's actually under review right now, where we reached out to multiple educators that we knew in our social circles, and we said, if you had to sum up the most important thing that you know about education into one sentence, what would it be? And my favorite response was, learning how to think is more important than learning about things. And if I could tweak that slightly, I would say, learning how to learn is as important as competence. We have to get people above this bar of excellence, this bar of good enough. And we have to teach them the self-directed learning skills to keep going so that they're on the upper curve and they don't take that downward escalator of competence. That's competency-focused instruction. Okay, last one. I hope you're hanging in there with me. I can't see anybody, so I don't know, but I hope you're still hanging in there. Tailored learning experiences. Competency-based education recognizes that humans are very different. We are not a monolithic group of people. And so can we start to improve the quality of education and the impact of education by making it less rigid and less standardized so that we can meet people where they are needed? And one way people have kind of operationalized this is through the idea of precision education, where we look for new sources of data inputs and analytics to then drive that learning process, and leaning both on learning theories, so being more deliberate with what we know about how humans learn and are motivated and grow, with these new digital tools, whether it's feedback dashboards, nudge strategies, those kinds of things. Let me show you just a couple of examples of what I mean. This is some work that's being done by a couple people here at Cincinnati. That's Dr. Turner and Seth Overlay. They are using AI to build some really cool interactive tools where our medical students and soon our residents can practice clinical reasoning cases. And not only are they dynamic cases that will go wherever the learner is trying to get them to go, but also gives them feedback on their clinical reasoning using known clinical reasoning frameworks. So how is your problem representation? How is your hypothesis generation and prioritization? How is your Bayesian analysis of probabilities as you do that? Like, it's a really cool way to try to be more precise to what each learner needs, because some people need help with their problem representation. Some people need help with their kind of probabilistic reasoning and those kinds of things. Really cool way to try to go about precision education. Up at NYU, there are some people who have built a really interesting method of pushing educational materials to learners based on what they saw in the clinical learning environment. And they do that by linking it to the electronic health record. So if you're a medical student and you saw a patient with acute kidney injury, without even having to do anything, they have a platform that will see that you wrote a note on somebody with acute kidney injury, and it will push you learning resources that are appropriate for your level of learner to learn more about those conditions. And maybe it pushes you 10 things in a day, and you pick the one or two that you think is most important for you to learn about, and then you can learn. Really cool way to do it. And if you're a resident, it might nudge you different things. Or if you signed a note on different patients, it'll nudge you different things. Really cool way to try to operationalize precision education and tailored learning experiences. It's even getting as cool as like what you would call haptics or wearable devices. So people are using this for surgical feedback. If you're doing a laparoscopic surgery, you can put sensors on the different tools and even on the proceduralists themselves. You look at who has the best outcomes and the worst outcomes. So who are the top performers and lowest performers. And you can build these like kind of movement phenotypes in terms of which movements lead to the best outcomes and use that for very specific microfeedback on surgical techniques. So cool. But even if you're not a proceduralist, which I'm not, People are using haptics for eye motion and seeing how are you doing when you're interacting with a concerned parent, or you're reading this chest x-ray, or you're evaluating this rash. Just really cool ways that 10 years ago would have sounded like science fiction, but are actually helping to provide feedback to people now. And in fact, speaking of science fiction, back in 2020, there was a call from the Journal of Graduate Medical Education to say, imagine what medical education will look like in 10 years. Write us some science fiction, be really creative. And my friends and I wrote an article pretending we had built these wearable devices like Doc Brown is wearing right there, that was reading the thoughts of residents and giving us feedback on what their clinical reasoning was doing. Because I can't see clinical reasoning. I have to watch behaviors and what people say and what they write in their notes, and it's kind of an imperfect measure. So we said, what if we built this device that would read your thoughts, and then we could really know how your clinical reasoning was doing? But then we kind of took a twist with it and said, what happens when you're invading privacy? So it's like a kind of a weird dystopian thought experiment that we thought was just for fun. But I started getting emails from people who are actually doing this work in other fields saying, hey, I'd love to collaborate you on your brain-computer interface project. So I don't think we're there yet, but like, all I'm saying is I don't think we can imagine where we might be able to go in terms of individualized training and precision education as technology and AI and our understanding of human learning gets better and better and better. I hope we never develop something that actually reads our thoughts, but I think there are ways that we can get an understanding of practice patterns and quality of care on a level that we've never been able to do before, which is really exciting. And even without all the fancy technology, maybe we can just reimagine kind of our paradigms of training and get rid of time as a measuring stick for readiness. There are so many studies out there, and for the sake of time, I'm not going to go through all of them, but so many studies that show that learners do not progress at the same rate, that we start in different places in terms of competence, that we end in different places in terms of competence. And if you overlay our learning curves, it's a big mess because humans are not uniform. And you might say, well, that might be true, but surely our training programs have been designed in a way to make sure that everybody's going to be done with a pediatric residency after 3 years, or medical school after 4 years. And some really smart people came together in 2017 to look at this. They said, what is the evidence for training for the amount of time that we do? And here's what they wrote. These are the best researchers from across the US at the time. And these are their words, not mine. History has not given a clear rationale for the need for any specific length of training for medicine or a given specialty, and that the length of training is basically arbitrary and historically and politically agreed upon entity that proved workable but never had empirically argued grounding. So just like for 200 years, we were just wrestling to standardize training approaches, what we landed on in terms of duration of training was not derived to maximize outcomes for patients. It was just kind of where we landed. And now that we are measuring the outcomes of training, we are seeing how variable those outcomes are, and we have to try to retrofit things. So maybe we need to move away from using time as a surrogate for readiness and move toward what we call time variable training. We should move away from fixed time variable outcomes more toward fixed outcomes variable time. And again, fixed outcomes does not mean everyone's the same. What it means is if we do set an aspirational bar of good enough or competent or entrustable without supervision, that we make sure everybody actually hits that bar, whether it's a shorter amount of time or a longer amount of time. We actually piloted something like this here at University of Cincinnati in our internal medicine program with just a subset of our learners. We call it timeless, and we progressed them in a time variable fashion. So rather than saying you're an intern for a year, we said you go until you're ready using our assessment system that we make that determination. And we found something really, really interesting in our competency committee, that when we implemented this for the subset of residents that we did, we didn't change anything about how the competency committee worked. All we told them was use all the assessment data that we have, because we'd already spent so much time on that. You just have the ability to progress somebody faster or slower, depending on your sense of their readiness. And what they told us in the committee was that they started really scrutinizing the assessment data and the decisions that they were making. That prior to this, it was kind of just a passive thing that you just presumed somebody was ready to keep going as long as there was no red flags. But this increased the weight of the decisions because they no longer felt like they could just rely on time and training. And it went from a very passive process to a much more active process. And one of the people in the committee used the analogy of a tightrope walker, that when you're in a competency committee making decisions about progression, and you have these time-based markers to guide you, It's like walking a tightrope with a net underneath you, so that like if you're not sure, you don't have data, that's okay. You've got the net to back you up. But this was like removing that net. So they really had to focus in on the data and make very data-informed decisions rather than just presuming readiness. And this was actually shown not just in this program. There was some work that, again, my friend Dan had done nationally, where he went and asked competency committees from across the US, how do you make decisions about readiness for practice? And how do you make decisions about when you can graduate someone? And most programs said, we just presume that we can. And what we called that was defaulting. If you look at the study in the upper left-hand corner, many programs were defaulting. In other words, they would graduate somebody or promote them, even if they didn't have evidence of readiness, as long as there was no red flags telling them that they weren't ready. So medical education in that model is like a treadmill that's just stuck in the on position all the time. And people get on that treadmill and they go to medical school and they do learn and they do grow and they do pass tests. Again, I'm not saying that there's nothing to education, but the default setting is that it is on and you just go through both the stages of medical education until you're in practice. And the only time that you turn the treadmill off is if there's a red flag, like an academic failure or a professionalism issue, something that jumps up and says, there's a problem here. Then we pause the treadmill and say, maybe you're not ready. But if there's no news, we presume it's good news, and we just say the treadmill is on. And what we found in timeless, time variable training, our competency committee members said it was like a totally different beast. This is totally different. Even though we didn't change anything for them other than make it time variable, they said this changed the treadmill to being off, and that they only turned it on at every time point once they had evidence of readiness for practice. So it was very much more of a, we are going to progress you when we have data that you are ready, or we have a defensible way of saying we think you are ready, rather than saying, no, we haven't heard anything bad, so we guess you're ready. And I think this is one of the major things that leads us to the point where we're graduating people we don't trust, because we just presume you're ready unless we hear otherwise. And then we get to the end and we say, you know what, maybe you're not ready. So I don't think you need time variable training to change the deliberateness with which we make these types of decisions. But I do think it's one mechanism in terms of individualized training that could get us there. So again, these are those 5 core components. They can look different across different programs, but if you want to do CBME, these are them. It is not a cookbook that you could just check these off. It can look very different depending on where you are and what specialty you're in, because again, it is a philosophy of training. And we always have to be balancing when we're trying to implement some philosophy, the fidelity to those core components with flexibility to implement it within our own settings and our own specialties. CBME can look very different depending where you are. And if you are going to go down this journey, I think one of the best ways to do it is invite friends. So it can't just be the educators and the CBME experts and the learner in the bottom there. We should have program evaluation experts and implementation scientists helping us. Because if we leave the implementation scientists out, we're going to risk having low fidelity implementation. We're going to just staple EPAs and milestones onto our current programs, and it's not going to be competency-based education. It's just going to be like a facade. If we leave out the program evaluation experts, then we might be evaluating the wrong thing, and we're going to be misaligning our expected outcomes with, what the program is actually designed to do. And if we leave us out as educators and leave our learners out, then we risk losing our North Star. So I think the best way to do this is to invite all of these people in. That's how you'll get high fidelity implementation, aligned evaluation, and we'll keep competency-based education focused on our learners and our patients. So I'm going to wrap up here and just say, imagine if, I love imagine if statements. Imagine if we had an education system where we had defined outcomes of training that we were aiming for and trying to assess, as flawed as they may be, and as often as they may need to be revised, we have something that we're moving toward. Imagine if we focused on not who's the best or worst, but getting people to some meaningful standard of competence and then giving them the skills to keep moving beyond that line of competence once they get beyond the walls of training. If we had programmatic assessment that was robust, that gave good feedback to learners and also helped us make defensible decisions about readiness, and that we could tailor our learning through precision education and maybe even time variable training someday. But the one thing I think we can't do is nothing. I don't think we can say, let's just keep doing what we're doing, because as I showed you, the outcomes of our training programs are not what we think they are. There are bigger gaps than maybe we want to admit. And I think if people are worried about this and saying, oh gosh, this sounds like this is going to challenge everything I think and do as an educator, I think we need to kind of embrace that. And I'll just end with this one sentence that comes from this very short perspective years ago by Kevin Eva. He wrote, health professions education would be an uninspiring place if every idea put forward was guaranteed to be long lasting. I truly hope everything I'm saying to you today becomes obsolete within 10 to 20 years, because that means we are moving forward and it's not about me. So if you are like really stuck in the Flexnerian model and think, I don't want to change, this is the way it is, I hope you're doing it because you think it's actually better than focusing on outcomes and not just because you don't want to change. We should all be willing to change. And if we're not changing as a field, then we're gonna get stale fast. So thank you so much. I really appreciate the opportunity to come chat with you all. I don't know if we have time for questions, but would look forward to questions either here in the moment or via email afterwards. Thank you.
Thank you. Yes, we do have time for questions. You'll raise your hand. I'll bring the mic to you. If you're in the room, if you're online, add it into the chat and we'll make sure to ask for you.
This is Sam Dotson, the program director. Thank you, Ben, for speaking with us again. It was great to hear this talk. One question I was thinking about as you were discussing competency outcomes is that so many of our outcomes are dependent on the faculty ratings, whether it's EPAs or competency-based medical assessment or the CCC. And when you talked about the OB example, we're kind of looking at hard outcomes data, which is obviously confounded by the patient population. But do you have a sense of if anybody has actually tried to catalog a list of outcomes measurements that can be pulled for graduates for each specialty and use that to determine which programs are actually doing a good job in these areas outside of the kind of the EPAs and which really rely on the faculty's input during residency?
Yeah, great question. Thank you for that. There are people who have tried to use different patient outcomes and like replicate the David Ash study. I've seen it in vascular surgery. I've seen it in mostly procedural based specialties. It might be out there. I've not seen anything in terms of like antipsychotics prescription rates or guideline concordant care or like vaccination rates for pediatricians or anything like that. That would be really interesting. But I do think hopefully we can develop educational measures that have enough validity evidence that they are meaningful to use as program evaluation. Meaning right now, one of my concerns is that I think many places just kind of staple milestones or EPAs onto what they're doing. And if you look under the hood at how those ratings are developed, sometimes it's kind of scary what you see. And so trying to compare programs or rate programs based on those kinds of ratings is a little suspect, because you're like, well, I think it's a little bit apples to oranges to compare, your milestone ratings to my program's milestone ratings, because how we develop those is totally different. But I do think that would be the ideal state, is if programs could invest in their assessment systems enough that those types of outcome ratings would be a meaningful measure of a program's functioning.
Thank you for your presentation. I was going to ask, do you think that there's a role for like nationwide, like American board level, practical kind of assessments? I know that there's usually like multiple choice question board exams, but like a practicum based or OSCE based national level exam, if that would be easier to implement as a standardized measure instead of like residency program specific things.
Yeah, thank you for that question. Such a great question. I do think that there is a role for that. And in fact, there are certain ABMS member boards that are already doing that and are moving even more toward that, trying to have a more programmatic competency-based way of doing board certification rather than just your performance on a multiple choice exam or an oral exam. I think some of the leaders in this space would be the American Board of Family Medicine, the American Board of Surgery, and the American Board of Pediatrics. I have no relationship with any of those, but they have really been out in front to say, what would programmatic assessment look like at the level of the board, whether it's integrating EPA ratings into board certification, which American Board of Surgery and Family Medicine have done, and American Board of Pediatrics is going to require of us as early as next year, whether it's having more simulation or case-based type assessment as part of your certification process. All those things are being done and are moving. Some boards are moving more toward it. Other boards are kind of sitting back and waiting to see what happens, because every change has side effects. But I do think there's a role for that at the level of the board.
All right. Thank you, Dr. Kinnear.